Afternoon, everyone.
Good afternoon.
On behalf of Indian Medical Association Karnataka and Indian Psychiatric Society Karnataka chapter, I extend a warm welcome to all of you for today's case conference. The objective of today's case conference session is to present, analyze, and discuss a clinical case in detail so that we enhance our understanding, improve our diagnostic reasoning, and also our management approaches. So, without wasting much time, I would invite our IMA Karnataka Honorary Secretary, Dr. Suri Raju sir, to read out the IMA prayer.
Good afternoon, everyone. Welcome to everyone to case conference. Let us start this program with ಮೊದಲನೇದಾಗಿ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಪ್ರಾರ್ಥನೆ. ಎಲ್ಲರೂ ಸಂತೋಷವಾಗಿರಲಿ, ಎಲ್ಲರೂ ಆರೋಗ್ಯವಾಗಿರಲಿ, ಎಲ್ಲರೂ ನೋವಿನಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲರೂ ದುಃಖದಿಂದ ಮುಕ್ತವಾಗಿರಲಿ, ಎಲ್ಲ ಆಸೆ ಆಮಿಷಗಳನ್ನು ಮೀರಿ ಗುಣಪಡಿಸುವವರು ನಾವಾಗಿರಲಿ. ಧ್ವಜವಂದನೆ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರ ಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನು ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ವಂದನೆಗಳು.
Thank you, sir. Thank you for the prayer. Now I would like to invite our academic committee, IMA Karnataka Academic Committee Chairman, Dr. Narayan Murthy sir, to welcome the gathering.
Thank you, madam. It's a privilege to present welcome speech for the occasion, which is a case conference which is conducted by Indian Medical Association KSP and Academy and Medical Education Subcommittee and Indian Psychiatric Society Karnataka chapter. First, I welcome our Honorable President Dr. V.V. Chinivalar sir to this program. Next, I welcome Dr. Suri Raju V. sir, Honorary Secretary, IMA KSB to this program. Also, I take this opportunity to welcome office bearers of Ipskc, that is Somshekar Bijal sir, President, Dr. Anil Kumar MN sir, Vice President, Dr. Narayan R. Mutalik sir, Honorary Secretary, and also Dr. Suresh CV sir, Joint Secretary, Case and Conference Moderator, Ipskc. Also, I welcome moderator of this session, Dr. K. Subrata Madam, who played a very vital role in conducting this program. And also, I take this opportunity to welcome chairpersons of this session, Dr. Anil Kakunje sir, Professor of Psychiatry, Yenopoya Medical College, Mangalore, and also Harish Delantabhattu sir, Professor and Head of the Department Psychiatry, SUIMS Shumaga. Last but not the least, presenter of today's session, Dr. Riaz Ahmad, Junior Assistant, Department of Psychiatry, SUIMS Shumaga. I welcome you also, sir, and also all the attendees of today's program, undergraduates, postgraduates who have already joined and will be joining. I welcome one and all. Over to you, madam.
Thank you, sir. Warm welcome to you too, sir. And also we will have Dr. Prashant, neurologist, consultant neurologist from Sarji Hospital, Shumaga, who has actually worked up this case together with Department of Psychiatry, Subaya Institute of Medical Sciences. So I also welcome, I extend a warm welcome to him as well. Now I move on to a few words I request Dr. Chinivalar sir to start the program with few words.
Brother, before that,
yes,
incidentally, Dr. Somshekar Bijal is a professor and head of the Department of Radha Institute of Medical Sciences. He is the president of Indian Psychiatry Society Karnataka chapter.
Yes,
Dr. Anil Kumar is a professor of psychiatry from KMC Manipal. He is the vice president cum president-elect. As well as Dr. Narayan Mutalik is a professor of psychiatry from Bagalkot, and he is the treasurer, he is the honorary secretary. And we also have Dr. Suresh CV, the joint secretary, and I heartily welcome all of them. And as you said, Dr. Shripuram is also going to join us soon. And I think we are expecting him at the earliest. He's a neurologist from Sarji Hospital to give his expert opinion. Thank you.
Yes, sir. Chinivalar, sir, please.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರ. ಇಂದಿನ ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ ಕೇಸ್ ಕಾನ್ಫರೆನ್ಸ್ಗೆ ಸೇರಿದಂತಹ ಎಲ್ಲರಿಗೂ ಸುಸ್ವಾಗತವನ್ನು ಕೋರುತ್ತಾ, ಇತ್ತೀಚಿನ ದಿನಗಳಲ್ಲಿ ಈ ಮಾನಸಿಕ ಆರೋಗ್ಯ ಸಮಸ್ಯೆಗಳು ಬಹಳವಾಗಿ ಕಾಣ್ತಾ ಇದ್ದೀವಿ. ಈ ಖಿನ್ನತೆ, ಆತಂಕ ಮತ್ತು ವರ್ತನೆಯ ಅಸ್ವಸ್ಥತೆಗಳು, ಅನಾರೋಗ್ಯ, ಇವುಗಳು ನಂತರ ಆತ್ಮಹತ್ಯೆ, ಇವೆಲ್ಲವೂ ಕೇವಲ ಏನಂತಲ್ಲ 15ರಿಂದ 30 ವರ್ಷದ ಒಳಗಿನವರೆಗೆ ಬಹಳ ನಾವು ಕಾಣ್ತಾ ಇದ್ದೀವಿ. ಯುವ ಮನಸ್ಕರಲ್ಲಿ ಮಾನಸಿಕ ಆರೋಗ್ಯ ಸಮಸ್ಯೆಗಳನ್ನು ನಿರ್ಲಕ್ಷಿಸುವುದರಿಂದ ಮುಂದೆ ಪ್ರೌಢಾವಸ್ಥೆಗೂ ಸಹ ಇವು ವಿಸ್ತರಿಸ್ತವೆ. ಸೊ ಈ ಒಂದು ಸಮಯದಲ್ಲಿ ದೈಹಿಕ ಮತ್ತು ಮಾನಸಿಕ ಆರೋಗ್ಯ ಎರಡನ್ನೂ ನಾವು ಏನಂತಲ್ಲ ಕಾಪಾಡಿಕೊಳ್ಳಬೇಕು. ಇದೇ ಒಂದು ದೃಷ್ಟಿಯಿಂದ ಈ ಒಂದು ಕೇಸ್ ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ ಏನಂತಲ್ಲ ಇದನ್ನ ಡಾಕ್ಟರ್ ರಿಯಾಜ್ ಅಹಮದ್ ಅವರು ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ತಿದ್ದಾರೆ. ಅನಂತರ ಅದಕ್ಕೆ ಡಾಕ್ಟರ್ ಅನಿಲ್ ಕಾಕುಂಜೆ ಮತ್ತು ನಮ್ಮ ನಿಯೋಜಿತ ಅಧ್ಯಕ್ಷರಾದಂಥ ಡಾಕ್ಟರ್ ಹರೀಶ್ ದೇವಂತ ಭಟ್ರು ಅವರು ಮಾಡರೇಟರ್ ಆಗಿ ಕೆಲಸ ಮಾಡ್ತಾ ಇದ್ದಾರೆ. ಸೊ ಜಾಸ್ತಿ ಹೊತ್ತು ತೆಗೆದುಕೊಳ್ಳದೆ ಇದನ್ನ ಏನಂತಲ್ಲ ಪ್ರೋಗ್ರಾಮನ್ನು ಸ್ಟಾರ್ಟ್ ಮಾಡಲಿ ಅಂತೇಳಿ ನಾನು ಕೇಳ್ಕೊಳ್ತಾ ಇದ್ದೀನಿ. ಆನಂತರ ಸುಬ್ರತ ಅವರಿಗೆ ನಂದು ಒಂದು ಬೇರೆ ಕೆಲಸ ಕಾರಣದ ಸಲುವಾಗಿ ನಾನು ಸ್ವಲ್ಪ ಹೊರಗಡೆ ಹೋಗ್ತಾ ಇದ್ದೀನಿ. ದಯವಿಟ್ಟು ಅಂತೆಲ್ಲ ಕ್ಷಮಿಸಬೇಕು, ದಯವಿಟ್ಟು.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಕನ್ನಡದ ಕನ್ನಡವನ್ನ ಮಾತಾಡಿದ್ರಿ. ನಾವು ಕೂಡ ನಮ್ಮ IPS ಕೇಸಿಂದ ಕರ್ನಾಟಕ ಮನೋವೈದ್ಯರು ಅಂತಾನೆ ನಾವು ಇಟ್ಕೊಂಡಿದೀವಿ ನಮ್ಮ ವಾಟ್ಸ್ಆಪ್ ಗ್ರೂಪಿಗೆ. ಡಾಕ್ಟರ್ ಬಿಜ್ಜಳ್ ಅವರು ಕೂಡ ಅದರಲ್ಲಿ ತುಂಬಾ ಕನ್ನಡ ಪರವಾಗಿ ಇರುವಂತವರು. As Dr. Harish sir said, Dr. Somshekhar Bijal, he is the current president of Ipskc, a very warm person who is very nice to work with. I invite Dr. Somshekhar Bijal sir to speak a few words.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ಮೊದಲನೇದಾಗಿ ಚಿನ್ವಾಲ್ ಸರ್ಗೆ ನಮಸ್ಕಾರ. ಯಾಕಂದ್ರೆ ಅವ್ರು ನಮ್ಮ ಪಕ್ಕದೂರವ್ರೆ, ಅವರು ಶಿಷ್ಯಂದ್ರು ನಾವು. At the outset, I would like to thank IMA Karnataka on behalf of Indian Psychiatric Society Karnataka chapter for giving us this opportunity to be the co-host for this case conference series. For the last 5 years, that is from 2020 onwards, the Ipskc is conducting case conference series every year, minimum around 6 to 7 per year, to enhance the equal type of presentation, especially with respect to the mental status examination to the post-resident across state in uniformity with the Mayorgas Proforma, what we use in NIMANS Bangalore oftenly. So in this this year, Dr. Suresh VC already completed 5 case conference series as a coordinator. So this is another case conference where there is also our colleague Prashant, whom we know all of you from beginning, from our NIMANS days. So he's with us. Appears to be very good case for learning, as well as the way it presented. Also, as the exams are nearing, especially in the month of September and October for PGs, so it will be definitely helpful. So with the aim of one is learning to the postgraduates, as well as the how to face the exam. That is the second aspect. So with this few words, I would like to thank once again IMA KSB for be the joint host along with us. And also I invite all the IMA people to join us for our 35th annual conference at Chikmagaluru, that is CANSIPS 2025, which will be held from September 12th to 14th. Thank you.
Thank you, sir. When we decided to have a case conference, the first thing I did was I talked to our HOD, Dr. Harisha Delantapettu, who is also a president-elect for 2026-27. So he was all okay for it, and he said, yes, we should go ahead. And we had a PG ready also, because a PG is under us in the department. Dr. Riyaz had to say okay. But then when it came to the moderator having a good examiner, I think Dr. Anil Kakunje sir, immediately he agreed. And I think that shows his greatness, because in spite of a busy schedule, he's agreed. So we have Dr. Harisha Delantapettu and Dr. Anil Kakunje as today's moderators, who are going to guide the student and all of us. So I invite our Associate Professor in Department of Subbaya Institute of Medical Sciences, Department of Psychiatry, Dr. Sai Komal, to introduce both of them.
Dr. Shripuram, Prashant Shripuram, the expert in the field of neurology, has already joined. Kindly.
Sir, Welcome, sir. A warm welcome to you, sir. We are very grateful that Dr. Prashant is here because he has worked up the case, a neuropsychiatric case. He has been the neurological input, whatever neurology related input he's the one who has given.
Thank you, madam.
Welcome, sir. Welcome. Sai Komal, yeah.
Okay. Sai Komal, kindly go ahead for welcome.
Okay, sir. Good afternoon, everyone. It's my privilege to introduce our chairpersons for today's session. Dr. Harisha Dalantabettu is a distinguished psychiatrist, academician, and a community leader from Bhadravati, Shivamogga. He currently serves as the professor and head of the Department of Psychiatry at Subbaiah Institute of Medical Sciences. Sir is the president designate of Indian Medical Association, Karnataka State Branch, and the member of Karnataka State Mental Health Authority, Government of Karnataka. Sir has previously served as the president of Ipskc between 2014 to 15 and has held several important public responsibilities, including member of Juvenile Justice Board, Shivamogga between 2017 to 2024, and member of District Inspection Committee, District Child Protection Unit, Shivamogga. He has also been the president of Sahyadri Neuropsychiatric Association at Shivamogga, and sir is currently the medical superintendent of Asha Kirana De-Addiction and Rehabilitation Center at Bhadravati. In recognition of his outstanding contribution, sir has been honored with the National Award of Indian Medical Association, and beyond his professional career, sir has represented Mysore University as an avid sports person and is also a very talented Yakshagana artist. So this reflects his versatile personality and his commitment towards culture and sports. So next up, we have our next chairperson, that is Dr. Anil Kakunje, sir. He is a professor of psychiatry at Yanapoya Medical College, Mangalore, a gold medalist in MD Psychiatry from KMC Manipal, and an alumnus of NIMHANS. Sir has over 115 publications, edited 19 books, and contributed to 9 chapters, with notable works like MCQs in Psychiatry and Rehabilitation Psychiatry. Sir has received prestigious Professor Raghuram Distinguished Young Teacher Award in the year 2018 and Young Psychiatrist Track Award from World Association of Social Psychiatry in the year 2016. He serves as Editor-in-Chief of Archives of Medicine and Health Sciences, Deputy Editor of Psychiatry Spectrum, and Field Editor of Indian Journal of Psychiatry. A mentor for Indo-US PR III projects, and is currently the guide to 7 PhD scholars. Sir has also pioneered a 24/7 psychiatry helpline at Yanapoya Medical College, which has been actively performing over the last 6 years. So hereby, I would like to invite both our chairpersons for today's session. Thank you.
Thank you.
So the platform is all yours. You can set the guidelines and then Dr. Riaz can start.
Prashant, can you introduce yourself because you are a neurologist from Sarji Institute of, then can you give
Prashant,
some
sir?
information? Prashant, sir? Dr. Prashant?
Sir must
He's
be
a
in the
busy
OPD.
neurologist. I think he's in the OPD. So for the past 2 days, we had holidays and he's busy with the patients, I am very sure. But he is kind enough to attend our online program. So he will join us anytime for any questions. He will be there. He will answer. Prashant, we are going ahead.
Yeah.
Right. We'll go ahead.
Sir, Dr. Anil sir,
I think,
how would you like to do? Yeah, Harish sir and Anil sir can tell Riaz what is the plan. He can start present.
Dr. Harisha can take the lead.
I think the external examiner, Anil Kakunje, I think she should be there as a chairperson. So I think you should be doing that.
Let him present the history of presenting illness. Then we'll take a break and then continue.
Okay, sir.
Fine.
Yeah, over to you, Riaz. All the best.
Yes, you can start now.
Good afternoon, everyone. Welcome to the case conference. Myself, Dr. Riaz Ahmed, Junior Resident, Department of Psychiatry, Shivamogga. Socio-demographic details. A 17-year-old boy studying in 12th standard, belongs to middle socio-economic status family, Hindu by religion, resident of rural Chikmagalur. Informants, boy himself and his father, information reliable and adequate. Chief complaints, episodes of headache, feeling of sadness, decreased interest in activities, episodes of unresponsiveness lasting for about 30 minutes to few hours, since 2.5 years, currently since 4 months. Main reason for consultation, increase in episodes of unresponsiveness since 4 months, reported to casualty in an unresponsive state. Duration, total duration of illness, 2.5 years, current episode since 4 months. Onset, insidious, course, episodic course, aggravating factor, upcoming 12th CBSE exams. Family history, second born out of non-consanguineous parentage, primary breadwinner and head of the family is father. Parents have arranged married life of 20 years. Descriptive account of family members. Father, 49 years old, studied till SSLC, farmer by occupation. Mother, 40 years old, studied till 7th standard, housewife. Elder sister, 19 years old, studying in BCA course, stays in hostel in Bengaluru. Grandfather, 75 years old, farmer by occupation. Grandmother, 65 years old, housewife. No history of any psychiatric illness in the family. History of hypothyroidism in elder sister. She is on treatment since 5 years. Family life and relationship. Extended family, total 6 members in family. Mother has permissive type of parenting and secure attachment style. Father has authoritarian type of parenting and father involved in disciplining and gets along well with elder sister. Family believes medical model of treatment. Personal history, prenatal factors, regular ANC checkups done. Perinatal factors, full-term LSCS delivery. At birth, birth weight 2.75 kgs. Baby cried immediately after birth. No history of NSU admission. First 4 weeks, nil significant. Developmental history, motor, cognitive, social, language milestones attained at appropriate age. Temperament, activity level, occasionally involved in playful activities. Rhythmicity, maintains regular biological functions. Distractibility, able to concentrate in ongoing activities. Approach to or withdrawal from stimuli, takes time to adjust with new situations and new people, has few close friends. Adaptability, not easily adaptable. Attention span, long. Intensity of reaction, mild. Threshold of responsibility, low. Quality of mood, positive. Impression, slow to warm up child. Schooling, age at admission to school, 4 years. Type of school, regular school. Academic performance, average scholastic performance. Change of school, from 5th standard, there is a change of school as parents wanted to join him in CBSE syllabus. Hobbies and interests, listening to music, reading books, and playing football. Past history, history of recurrent upper respiratory tract infections in childhood, history of adenoidectomy at the age of 14 years, history of chronic urticaria from 3 years on tab levocetirizine 10 mg. Treatment history, tablet escitalopram 15 mg for duration of 6 months. There were no side effects. There was a good response. Tab divalproex 500 mg for a 6 months duration. There was no side effects noted and there was a good response. History of presenting illness, 17-year-old boy, apparently doing well till 2.5 years back. Then he started reporting of episodes of headache, which was insidious in onset and gradually progressive. Initially, he had episodes once a month, which gradually increased to 2 to 3 episodes in a week. Headache began in one side of the head and then it became diffuse. It was described as a throbbing type of headache and was associated with nausea, blurring of vision, dizziness, sensitive to light, and loud sounds. Each episode lasting for 6 to 12 hours. It used to aggravate on going out in sunlight, loud noises, and hunger, and however, relieved on taking painkillers and rest. Following which, boy started reporting of sadness of mood throughout the day. He used to hardly interact with family members and was preferring to stay alone in his room. When family tried to take him on outings, he always avoided them and preferred to stay back home. He reported of feeling tired even on getting up from bed and doing his regular course. He would just lie down on bed and watch videos on his phone for an entire day. On some occasions, father would force him to do his daily course and to attend school. At school, he started losing interest in extracurricular activities like playing football, which was his favorite sport in his school with his group of friends. He used to prefer to sit in a corner and just remain on his own. In the school, he would hardly listen to the classes and write notes. He appeared as if he was preoccupied, due to which he started to have incomplete academic work. He reported of difficulty falling asleep and used to have frequent awakenings in the night. And next morning, child would wake up feeling tired, and hence he would lie on bed unless he was forced to do his daily course. Father also reports that patient gradually started to skip meals as he did not have the appetite. Even when parents used to force him to have food, he would eat very less food and leave rest on the plate itself. Following this, it was noted that one day when he was in school, father got a call saying that child is not responding. When father rushed to see him, he was found to be lying down and not responding to any verbal comments. Then he was immediately taken to hospital. Upon reaching hospital, child regained his consciousness. He reported of feeling dizzy before the episode and does not have a memory of other details during episode. In the coming few days, child had many such episodes of responsiveness at home as well as in the school. Each of the episode had similar symbology wherein it used to begin with a headache, blurring of vision, and then dizziness associated with weakness of the lower limbs. And he would try to hold the wall, take support, and lie down on bed gradually with his eyes closed. These episodes have lasted for a minimum duration of 30 minutes to sometimes almost for a day. When they tried to wake him up by sprinkling water on face and calling his name, he used to not wake up, neither respond to them. During the episodes, he doesn't take food and there is no bowel and bladder incontinence. Upon waking up, he complains of difficulty in walking, dizziness, and swaying for the next 2 to 3 days. As the episode progressed, child was frequently missing school, and even on the days he went, he reports that his friends used to make fun of his illness and his appearance, due to which he would further avoid going to school. Then family took him to the psychiatrist and the treatment was started. In the next 2 to 3 months, child was better in symptoms with respect to feeling sad, started gaining interest in school, and it was noted that his episodes of unresponsiveness also decreased. He was reported to be better for a period of 9 to 10 months. During this time, he finished his 10th exam and got 70% and finished his 11th standard and went to 12th standard in the same school. He then began to skip the medications thinking that he is all right. However, since last 4 to 5 months, child started to have all the above symptoms. When he started to have, since 4 to 5 months, he had parents have taken him to the psychiatrist and was started on the treatment. Treatment will be discussed further and was brought to the casualty. Here he was brought to the casualty in an unresponsive state. Negative history. No history of rhythmic movements of bilateral upper limbs and lower limbs. No history of uprolling of eyes. No history of tongue bite, frothing, urinary incontinence. no history of hearing of voices in isolation, no history of suspiciousness, no history of talking to self or smiling to self, no history of over familiarity and over talkativeness, no history of repeated irrational thoughts, no history of running away from home, no history of stealing things or lying, no history of harming animals, no history of any other substance use, no history of diabetes mellitus, seizures, head injury, TB, and asthma. Yes.
Okay, thank you. I think we'll take a small break and come back. Shall we
Yes, sir.
open it to the audience? Any questions from the audience before we start?
Yes, sir.
Anyone from the audience wants to ask anything, you can unmute and ask the presenter. Okay. If there are none, you can still type on the chat box and we can take it up if it is important. Harisha sir, who will start first?
Yeah, I appreciate Riaz. Riaz is a second year resident and just finished Niman's posting and has come back. Now that he has taken that child performer, so he has gone to family history first and then he has explained. I think, yeah, it's reasonably good, but the question wise, uh, in the past treatment history, what he was talking about, they have put escitalopram and divalproex.
Yes.
So what do you think that putting divalproex there? What is
So
the
Divalproex was
what
started
is
for
the logic behind putting divalproex there?
for migraine prophylaxis, sir.
500 milligram divalproex.
Yes, sir. Prophylaxis for migraine headache.
Okay. Is that possible? The episodic fall, unconsciousness. Is there anything, something to this, whether the physician has thought something else also?
For to like if there is a history suggestive of any seizures, like as anti-epileptic also it, and as a mood stabilizer also it can be used, sir.
Yeah. Yeah. Who has put this divalproex? Neurologist?
No, sir. Psychiatrist, sir.
Good. Anil?
Yes. Fairly good history covering a lot of things, Arif. So, Riaz, so one question. Can you describe all these episodes were similar or different in nature?
Semiology, similar, sir.
Similar. So, can you describe one episode in little more detail?
Yes, sir.
Exactly what happens during these episodes?
Yes, sir. Should I? Before just before the episode, he used to complain of headaches, sir, and dizziness, and blurring of vision, and weakness in the lower limbs. And following which he used to take support of the wall or the nearby support whichever is there, and then he used to lie down there, sir. Then he used to be unresponsive. Duration depends from 30 minutes to 1 day, during which even if someone tries to wake him up or someone tries to sprinkle water, he used to not respond, and there is no like any upper limb or lower limb movements, and he used to and then following which he used to he himself used to wake up, and then following which he used to again complain of dizziness, blurring of vision, weakness, like this, sir. These, like, all the episodes are of this semiology.
Yeah. So basically, what I was planning to ask is, have you done a ABC analysis? Generally, is there a pattern of some antecedent happening and he has this behavior? And what happens after this? Do you see a pattern in some kind of preceding event before the episodes of unresponsiveness? Is there something which is common? So
Like
exams,
stress
reading,
or
or test?
exam stress is there, sir. Along with that, father used to scold him, and headache used to precede before that.
Were these episodes happening in school or at home?
Yes, yes, sir. School as well as in home, both settings, sir.
Okay.
Here.
So generally, when children come with such kind of complaints, it's
Yes,
always
sir.
nice to ask, does it happen on Sundays? Does it happen on holidays? Does it happen
Yes,
on
sir.
vacations? Say when there is
Yes,
a summer vacation, 2 months there is no reading. So
yes,
have they
sir.
observed him having episodes even on holidays?
That thing actually, like, yes, sir, but it is
Dr.
like,
Riaz, you can take Dr. Jain also. She's your senior PG. She has also worked up the case. You can take her as well. She can give
yes,
some,
ma'am.
if she has more input, she can give.
Yes, ma'am. Yes, ma'am. Yes.
No, there is no issue. I mean, it is always good to ask when children come with academic problems. It's always
Yes,
nice you ask what happens during holidays, weekends,
yes,
and vacations, and so on. Generally, during vacations, it is not there. And many times, mother, parents also observe that Sunday it is not there, Monday
yes,
morning it starts, maybe holidays it is not there, and so on.
yes,
So
yes.
it gives us
The,
an idea, a clue to a possible psychiatric overlay and psychiatric component to the symptoms.
yes, sir.
Okay.
Sir, in this, like, that pattern was not observed, sir, because it was 10th, 11th, 12th, 10th board exams. Like, before that, it had started, and then 11th he was maintaining well. Again, then as 12th board, like 12th he has entered. Again, it has been started, sir. So
Okay. So it
yes,
looks as if it is predominantly related to academic stress.
yes, yes, sir, yes, sir, yes,
Yeah.
sir. Yes.
Why was the change in school? Why did they change the school?
Sir, first to fourth standard, he was in a state syllabus, sir. His parents wanted him to join him, take him admission in a CBSE syllabus school. So that is why from fifth standard they made him admission in the school which has CBSE board, CBSE. Yes. And also
Okay.
it was school, that CBSE board, and also the school was near to the home, like their home,
Okay.
sir.
So what is the aspiration of the parents, or what is they looking forward to by putting him in the CBSE school?
Uh, so that he can, like, he can study, like he can study in a better better board. And his father was as per, like, he was thinking of making me engineering, sir, engineer like that. So he thought
Correct. See, generally,
maybe
parents will have their own idea about he should be a doctor, engineer, and have
yes,
some high
yes,
aspirations, which sometimes
yes,
doesn't match with the child's ability or the child's interest.
yes.
Okay. So, so any movements you see during these episodes?
No, sir, no rhythmic movements, no abnormal movements, nothing. No, sir.
Okay. These unresponsive episodes, what purpose does it serve to the child?
Uh,
What does he gain from this?
sir, first that's like missing, like the gains, like if we consider the secondary gains, first is the attention and care from the family, sir, and then the emotional relief from the getting scolding from the father, that is like critical comments, and then escape from the responsibilities like academic stress, and like relieving, like temporary relieving from the his high expectations, and also social benefits such as sympathy and support from the teachers and friends.
Okay.
Yes.
Is there any modeling for him? Or what is modeling?
No, sir. Like
Does he have a modeling?
no, sir. Nothing like that. No, sir.
Modeling is when generally such say people say get the idea from somewhere. Sometimes family members or friends
No,
or
sir. No.
someone in
Yes,
his
sir.
known circle having such kind of problems.
No, sir. No family history or any other like surrounding or nothing.
Generally, these children catch these symptoms from school. So, did you ask?
Yes.
So, anyone in school having falling episodes during prayer,
No.
someone falls and doesn't stand for the prayers. So then he learns that if you fall, then you need not go through the problem of standing. So from there he catches the symptom.
No, sir. Nothing. No, like nothing.
Right. So anyone else wants to ask anything or contribute?
Sir, there are 2 questions in the chat box that can be taken.
Yes. Yeah, you can just read, Subrata.
How's the interaction between family and friends of the child? They're asking how does the child interact with other family members and friends? Yes.
Yes, ma'am.
Yeah. How's the interaction between family and friends?
Like whenever this like episodes used to happen, like
No, maybe I think they're asking not when the episodes happen. It is just like that. I think temperament you have told us, no, slow to warm up.
yes,
Some
ma'am.
clues can be taken from there, what you have written. So you can tell us from that.
Like for like.
Ma'am, if you could repeat your question, I think.
How's the interaction between family and friends?
Sir, ma'am, actually he had less friends compared to like usually he had less friends. He has difficulty making friendship and all. So like, whatever few friends he had like they used to ask about him, but not much interaction.
Okay. The other question by Dr. Suresh VC is what was the trigger for onset of depressive symptoms? Specifically wants to know whether there were any death wishes, suicidal ideas. Yes or no, death wishes?
No death
No.
wishes or
Second
suicide.
thing is whether child had any explanation about his symptoms. ನನಗೆ ಯಾಕೆ ಈ ತರ ಆಗ್ತಾ ಇದೆ? If you ask him ಯಾಕೆ ನಿನಗೆ ಈ ತರ ಆಗ್ತಾ ಇದೆ ಅಂದ್ರೆ does he have any explanation?
One thing was the headache. He was like referring to the headache, ma'am, and other things, exam stressors.
Actually, because I have also seen the case, it is mainly, I think, he would always give headache. ನಂಗೆ ತಲೆನೋವು ಕಡಿಮೆ ಆದ್ರೆ ಸರಿ ಆಗತ್ತೆ ಅಂತ. He would not acknowledge any other explanation as such.
Yes, ma'am. Yes, ma'am.
Maybe over 6 months after seeing in therapies, it has changed. But then initially when he came, it was only ನನ್ನ ತಲೆನೋವು ಕಡಿಮೆ ಆಗಬೇಕು.
Yes, ma'am. Yes, ma'am.
And academically, he was reasonably doing well whenever he has gone to classes, right?
Yeah,
He has not
yes,
had
ma'am, yes,
academic deterioration as such.
No, like
Fine.
10th also
Yes.
he was passing
Yes, yes. Yes, sir.
70%.
Yeah, Dr. Prashant wants to add anything?
Yes, I just want to ask one thing.
Yes.
What I understand is all the discussions are going around functional, psychiatric illness. So
Yes.
if at all, if it is not psychiatric related, if it is a organic disease, what will you think about in these episodes?
Correct.
Organicity, like seizures we can think of, sir. Status epilepticus and autoimmune encephalopathy.
Okay, please tell me.
Yes, sir. Autoimmune encephalopathy we can, and then
So since it is a psychiatric
any obstructive sleep
obstructive
disorders.
sleep apnea, you are thinking, right?
No, sir. Like sleep disorders, any sleep disorders?
Oh, okay. So, hello?
Yes, sir. Yes, sir.
Yeah, since it is a basically, I understand all the audience are psychiatrists, PGs who are going to be psychiatrists next. So I just want to add upon here. This is episodic
Okay, sir.
altered sensorium. So how will
Yes.
you approach to a patient who is having recurrent episodes of altered sensorium? Not in this case. In any case, if somebody has got recurrent episodes of unconsciousness or altered sensorium, what will be your basic approach for them?
Sir, first, like when he has presented to the casualty, first we'll rule out the like reversible causes such as hypoxia or hypoglycemia or any toxins, anything like that. Then we'll do the basic like RBC.
Sorry to interrupt
RBS.
you. Sorry,
Yes,
I'm not
yes,
talking casualty case. See, because what
yes,
happens is whenever they come to casualty, I understand psychiatrists will not be involved when a
yes,
acute case
yes,
come into a casualty.
yes,
Okay,
yes,
so by the time they come to you, it will be a outpatient only,
yes, sir,
and
yes,
they will not be sick.
yes, sir.
Correct? Yeah. So once the somebody is having recurrent episodes and they are not coming in a altered state to you directly, so then how will you approach to such patients actually? You already told it, doctor. One is you told seizures, right? It can be
Yes, sir.
seizures. Then
Yes, sir. Then like organicity.
NMDA.
Madam, actually, he told about autoimmune encephalitis.
Yes, yes, sir.
But what I want to add here is, if somebody is having autoimmune encephalitis, they don't come with recurrent episodes of altered.
Okay.
I mean, like they can have seizures. So if you see it as seizure, okay, then we have to start ruling out the causes for seizure. But autoimmune encephalitis will not come with recurrent episodes like this. They will have something which is going on in the background. Like they will have a neuropsychiatric manifestations, some behavioral issues, and many times they end up in psychiatry only. I do understand. But here, only seizure like picture is.
Transient ischemic attack, TIS, or any.
Yeah, it's a very good answer. Transient ischemic attack.
Yes,
Yeah,
sir.
but regarding transient ischemic attack, what I would like to add is they don't last for 24 hours and all like this.
Yes, sir.
Usually they last for few seconds or minutes or maximum hours also they should not last normally.
Yes.
Okay, but still you have to think transient ischemia, okay? Because whenever somebody comes with a recurrent episodes, we always consider ischemia as one of the DD. Then next one.
Then metabolic causes.
Sir, what
Yeah,
about post-migraine?
Yes, madam. It is a complicated.
Post-migraine, complicated migraine.
Yes, madam. We have to think migraine. Migraine is also something which comes and goes, and which is a favorite topic for both neurologists and psychiatrists. But complicated migraine can present with a prolonged abnormality like this, but they're quite rare. But still, we have to consider one in the background. Then, sorry.
Any tumors or any to rule out any tumors, space occupying lesions.
See, space occupying lesion. See, you are going into a diagnosis. I mean, you are going to etiology now. I am still in the broad syndromes. Okay, because raised tumors will come either with a raised intracranial tension or they come with focal neurological deficits or they can come with seizures. So already we have discussed it can be a seizure.
Can it be metabolic cause?
Madam, yeah, we had to think metabolic, but again in metabolic, it can't be simple metabolic like hypoglycemia or so because he is non-diabetic. And yeah, still we have to rule out any hypoglycemia because non-diabetic hypoglycemia, they can come with some pancreatic tumors and all. One is hypoglycemia, but more than that, I would like to rule out any ammonemia, some sort of hyperammonemia or some sort of metabolic disorder.
Sir, someone in the chat box has also written about periodic paralysis and paroxysmal vertigo.
Yes, they are also differential diagnosis in such cases because whenever somebody comes and goes, paroxysmal movement disorders also can come, but they will not have loss of consciousness. They will only have abnormal involuntary movements like that, something like that they will have. But since paroxysmal vertigo, again, they are all like a part of migraine spectrum actually. But here the problem is it's not just vertigo. He used to be very unresponsive and all. It was more than vertigo in this patient.
Okay, Anil sir.
Yes, I think we covered most of the paroxysmal disorders now. Yeah.
Thank you, sir.
Thank you.
I think we let Riaz continue and
Yes.
we listen to the rest of the history.
Correct, sir.
Yes, sir.
You can continue, Riaz.
Yes, sir. Yes, sir. General physical examination. A post-wakefulness state after a 16 hours of unresponsive episode. Patient was lying on bed, well-built, nourished, conscious, cooperative, oriented to time, place, and person. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema. BP 130/90 mmHg, pulse rate 100 beats per minute, regular rhythm, normal rate, and good volume. All peripheral pulses felt. SpO2 99% at room air, weight 75 kgs, height 160 centimeters, BMI 29.3 kg per meter square, temperature 98.2 Fahrenheit. Then head to toe examination, acanthosis nigricans present, gynecomastia, grade 2 gynecomastia, central obesity noted, large nevus noted over the right side lateral aspect of the umbilicus to the hypochondrium, extending approximately 20 into 15 centimeters. Diffuse swelling over anterior aspect of the neck, which is non-pulsatile and soft in consistency. Systemic examination, respiratory system, bilateral normal vesicular breath sounds, no added sounds. CVS, S1, S2 heard, no murmurs. Abdomen, soft, non-tender, no organomegaly. Then CNS examination. In cranial nerve examination, all the cranial nerves were examined and it was normal. And motor system, attitude was normal, bulk normal, tone was normal, power was 5/5. Then reflexes, superficial reflexes were present. In deep tendon reflexes were exaggerated. Biceps jerk, triceps supinator, knee and ankle jerk were exaggerated. And sensory system, spinothalamic normal posterior column. In Romberg sign, it was positive, he was swaying to the left side. Like cerebellar signs, titubation absent, truncal ataxia or gait ataxia, difficulty in establishing gait. On examination, patient had difficulty in standing upright with swaying to the left side, and tandem walking unable to do. Then there are no signs of meningeal irritation. Then mental status examination, general appearance and behavior. Patient lying on bed, moderately kempt, rapport established, eye-to-eye contact momentarily maintained, occasionally tearful, no tics, no stereotypy, no mannerism. Psychomotor activity normal, speech tone reduced, tempo volume normal, reaction time normal, relevant and coherent, prosody maintained. Then thought, ನ್ಯೂಟ್ರಲ್ ಸ್ಪೀಚ್ ಸ್ಯಾಂಪಲ್. ನಾವು ದೀಪಾವಳಿ ಒಂದು ದಿನ ಮಾಡ್ತೀವಿ. ಬೆಳಿಗ್ಗೆ ಎಲ್ಲರೂ ಸೇರಿ ಪೂಜೆ ಮಾಡಿ ಆಮೇಲೆ ಅಮ್ಮ ಸಿಹಿ ತಿಂಡಿ ಮಾಡ್ತಾರೆ. ಮಧ್ಯಾಹ್ನ ಎಲ್ಲರೂ ಸೇರಿ ಊಟ ಮಾಡ್ತೀವಿ. ಆಮೇಲೆ ಸಂಜೆ ಲಕ್ಷ್ಮೀ ಪೂಜಾ ಮಾಡ್ತೀವಿ ಹಾಗೂ ಪಟಾಕಿ ಹೊಡಿತೀವಿ. ಫಾರ್ಮ್ ಆಫ್ ಥಾಟ್, ನೋ ಡಿರೇಲ್ಮೆಂಟ್, ನೋ ಒಮಿಷನ್, ಸಬ್ಸ್ಟಿಟ್ಯೂಷನ್, ಡ್ರಿವೆಲಿಂಗ್ ಥಿಂಕಿಂಗ್, ಡಿಸಲ್ಟರಿ ಥಿಂಕಿಂಗ್, ಕ್ಲಾಂಗಿಂಗ್. stream of thought, no flight of ideas, no prolixity, no circumstantiality, preservation and thought blocking, possession of thought, no obsession and compulsion.
You can tell important findings.
Yes,
You
sir.
can tell only the important findings. That should be enough.
Yes, yes, sir. Yes. Content of thought, inference from the above verbatim, ideas of worthlessness, and also ideas of helplessness. Mood, subjective, bejaride, objective, dull effect. Range normal, reactive, appropriate to situation, and congruent to thought content. Cognitive function test, attention and concentration, impression, attention aroused and sustained, memory, impression, memory intact, intelligence, impression, adequate intelligence for his education background, comprehension intact, arithmetic, impression normal, abstraction, he is able to say similarities and dissimilarities, proverb, impression intact, judgment, intact judgment, insight grade 3, that is awareness of being sick but blaming it on external factors. Diagnostic formulation. Master A, 17-year-old boy, studying in class 12th, belonging to middle socioeconomic status family, Hindu by religion, resident of rural Chikmagaluru, with temperamentally easy child, with personal history of bullying and school refusal, with family history of hypothyroidism in elder sister and high expressed emotions, criticality, hostility from father, with past history of upper respiratory tract infection, adenoidectomy, urticaria on treatment, and history suggestive of moderate depression with somatic symptom, dissociative stupor, migraine headache, for which he was treated and had improvement. Later discontinued the medications and was maintaining well for almost duration of 10 months to 12 months. Currently presented with illness duration of 4 months characterized by headache, low mood, anhedonia, decreased sleep, episode of unresponsiveness with significant biosociooccupational dysfunction. On GPE, there was acanthosis nigricans, gynecomastia, grade 2 gynecomastia, central obesity, large nevus over the right-sided lateral aspect of umbilicus, the hypochondrium extending approximately 20 into 15 centimeter, and diffuse swelling over the anterior aspect of the neck, which is non-pulsatile and soft in consistency, with a BMI of 32 kg per meter square. MSA is corroborative and with intact judgment and grade 3 insight.
Okay. So just hold on. Any questions from the audience till this stage? People can also type. Harisha sir wants to ask anything?
Yeah, that is fine. The presentation is fine. In diagnostic formulation, what the presenter thinks about the case.
Yes.
Recurrent depressive disorder. Current episode is a moderate depression.
With somatics. Yes.
Sir, just a moment. Dr. Vinayak Bhatt, our Dean of Subaya Medical College, has joined us in the hall, Council Hall. A warm welcome to you, sir. Yes,
Good afternoon, ma'am.
good afternoon, sir. Yes, sir. Dr. Riaz, you can continue answering Dr. Harish's question.
This is as per which criteria provisional diagnosis is done axis-wise?
Rutter's multi-axonal diagnosis, sir. ICD according to ICD-10, F33.11, recurrent depressive disorder, current episode moderate depression with somatic symptoms, and F44.2, dissociative stupor.
What are the points in favor of moderate depression?
Sir, first typical symptom, like major symptoms, depressed mood, loss of interest and easy fatigability, and he has diminished appetite, decreased sleep, and somatic symptoms, loss of interest in previous pleasurable activities, waking up early in the 2 hours normal to his previous timings, and
What made you to say it's a recurrent depression? Uh, is there any symptom-free interval between the episodes?
Yes, sir. Yes, sir. From almost 9 to 10 months, there was a symptom-free, sir. From 24 to 25, like in between that, 2024 to 2025, there he had a symptom-free period, sir.
With the medication or without medication?
Off medication, sir. Without medication.
Yes, can you just project the life chart once?
Yes, ma'am. Yes, ma'am.
Please. This depressive episode is different than the unresponsive episode, correct? There was a episode of depression previously treated. Yes.
Yes, ma'am. Yes, ma'am.
There's a question in the chat box. How do you explain CNS findings?
Yes, ma'am. Yeah.
CNS findings, you mean history of unresponsiveness or any other findings?
No, when he
Dr.
presented...
Sharma, no, not you. Dr. Sharma has asked about how do you explain CNS findings?
Is that in the history or in the physical examination? CNS
Yes,
findings?
she has written exaggerated reflexes.
Yeah, just on examination, you have to explain.
Maybe, I think it was during the episode, whatever was done, the examination, CNS examination. I think after
yes,
the
ma'am.
episode also, yes?
When he presented to the casualty, after half an hour when he woke up, we had done the examination, ma'am. However, after 2 to 3 days, like the exaggerated deep tendon reflexes were normal, and gait was there was no any abnormal gait, and also there was like he was able to do like tandem working was normal, no abnormalities detected, ma'am.
So maybe that's the reason we want that episode should be further evaluated by a neurologist.
Neurology, yes, ma'am.
Correct. Yes. I think that answers Dr. Shama's question. I think Harishma Ajit is asking, how do you explain, is the patient doing any blood test like HB? I think that he will come later. He has
Yes,
it.
ma'am.
Yes, he has it.
Whether Dr. Sripuram is there to explain that CNS finding, whether he has got any question?
Sir,
I am disturbing you. I think I am sure you are there in the busy OPD.
No, sir, no problem.
Please.
Sir, actually, when I examined him, by that time reflexes were normal. So I saw him 2 times, but both the time reflexes were normal. But it was very difficult to tell exactly why there was brisk reflexes at the time of initial presentation, actually.
According to you, there are no neurological findings on examination.
No, sir. When I saw him, I didn't find doubtful rhombus. What they have mentioned here. Hello.
Yes. Audible.
Yeah. Even that also, I am not convinced, because by the time I had seen him, both the time it was normal. And we had done sorry, I think I'll come to it later. Yeah.
Even EEG will be told later.
Anil, do you have any questions? Do you have any doubts?
Yes. If we see the person during the episode, how will you distinguish between, say, psychiatric cause for the problem or whether it is organic? You see a person who is unresponsive and saying, I am unable to move. So what are the tests with which you can say whether it is a dissociation or whether it's an organic problem?
Yes, Dr. Anil, before that, I just want to add one more thing here.
Yes.
That exaggerated reflexes again. Hello?
Yes, sir.
Yeah, I'm audible, right?
Yes.
Yes, sir.
Exaggerated exaggerated reflexes without plantar extensor, sometimes you may have to take with a pinch of salt actually. Because if there is 3 plus reflexes, plantar should be extensor. So that is one thing I would like to add here. And exaggerated reflex with extensor plantar will tell us that there is some pyramidal tract involvement bilaterally. So that only way we have to do is by imaging, like we have to keep it open in that way. I'm just telling how we can approach to both conditions here.
Riaz can tell any tests which we can distinguish between, say, dissociation and an organic problem.
Sir, dissociation, like example to differentiate it between seizures and this thing, dissociation. Serum prolactin can be done, sir, for differential pseudo seizures and seizures, and other things like EEG and
No, not the investigation, any physical
Clinical.
test, any clinical test. Have you heard of Hoover's test, abductor test?
yes, sir. Like when we the abdominal umbilicus will be yes, sir. Yes.
Doesn't matter. So there are tests with which probably clinically we can suspect the possibility of a dissociation is high. The test like Hoover's test, abductor test, knee drop test, hand drop over the face test.
Yes,
so few of the things clinically which can do and probably give some indication that probably it is psychogenic.
Yes.
Okay. In this case, can you tell what is possibly the predisposing factor, the precipitating factor, and the perpetuating factor?
The precipitating factor is like it should like onset of the illness, the reason for
Yes.
the onset of the illness.
Yes. So what was there? What was there?
Exam, maybe like exams, sir, exams.
Exams. Yeah, correct. And the predisposing
And
factor?
the predisposing factors like the temperament of the child that is
Okay.
slow to warm up. Yes, sir.
Yes.
And perpetuating is the maintaining factor of the illness. The critical comments from the family, that is hostility, those all things. And aggravating factor is which worsen the illness, that is upcoming board exams, that things.
Okay. So maybe his academic expectation from him, from the parents, that also would have been academic difficulty, also would have been a predisposing factor. People's personality as the or temperament, as you rightly said, that also can be a predisposing factor. So there are multiple things because he's been having episodes, he's been having some psychological disturbance before the current increase in symptoms. It is very likely there is something which is need to be carried out on a long-term basis so that he doesn't have much episodes in future also.
Yes.
Okay. So any scales are there to look at, say, dissociation?
Yes, sir. There is a scale like dissociation experience scale, DES, which has 28 questions like to be self administered, like in which can be rated from 0 to 100%. Then we will calculate the mean of all the 28, and then we can give a rating for that, sir.
Okay. Earlier, this used to be sometimes called as hysterical behavior or a hysterical symptom. Why?
In the history, it was like in the medieval ages, like that. It was prevalent in women.
So,
like it was
it comes
from
from it comes from the word hysterus.
Uterus.
Yes.
Entering uterus.
Correct. So, what are all the common symptoms of dissociation which you generally see? clinically? Types of dissociation.
Different types, like
Common ones.
Dissociative convulsions,
Yes.
transient possession attacks.
Okay.
Dissociative fugue.
Common.
Fugue is not very common.
Yes, sir. Dissociative amnesia.
Okay.
Dissociative like an aphonia things around.
But commonly what you see is dissociative motor disorders.
Motor
Where
disorders.
patients are unable to move hand, move leg, and so on.
Yes.
Okay. So you want to tell anything more in the history regarding management plan, diagnosis and management plan?
Yes, sir. Management plan will be discussed. Yes, sir.
Yeah, you can continue so that we
Yes.
can complete the case.
Yes.
Yes.
It's 3:08 now. We can continue for another 15 minutes, probably.
Yes. Yes.
Okay. Management plan. Inpatient care in view of patient reporting to casualty in an unresponsive state of 16-hour long duration, and also to rule out the organic cause. And when the patient becomes symptomatically better, we will planning for intensive inpatient psychotherapy. And then investigations, which we like to send is CBC, LFT, RFT, serum electrolyte, ECG, RBS, TFT, urine routine, MRI brain, and EEG. Scales which we have applied is childhood depression rating scale. In that score is 60, which gives impression as moderate depression. Pharmacological management, plan to increase tab desvenlafaxine up to 100 mg and to give adequate dose and adequate duration trial. To continue tablet propranolol and flunarizine, and to continue tablet levocetirizine 10 mg. And also to ensure adequate food intake and hydration.
You're not audible, Riaz.
You continue.
Continue.
Yes, hello.
Yes.
Yeah. Continue.
Yes, since 4 to 5 months, as symptoms were there, he had went to the psychiatrist. There he was started on tab desvenlafaxine. So we now 75 mg. So now currently we are planning to increase desvenlafaxine up to 100 mg. And endocrinologist opinion in view of Cushing syndrome, and neurologist opinion to rule out the organic causes. And non-pharmacological treatment, first we'll have do psychoeducation to explain family members about the medical model of illness and importance of treatment compliance, and to reduce the secondary gains of the boy, encourage him to attend school, and decrease criticality and addressing expressed emotions in the family, and identify his positive behavior and reward for his positive behavior, and encourage healthy lifestyle. In non-pharmacological treatment, we have supportive psychotherapy. Initially, we have done the supportive psychotherapy. Initially, we offered supportive psychotherapy. That is weekly
Riyaz,
sessions.
Riyaz. Now that what do you want? What is your diagnosis? Now that you have a provisional diagnosis, then you went for some investigation. I would like to know what is the result of those investigations.
Yes, sir. It is there, sir.
Now you tell me. Then you go for psychotherapy.
Yes, sir. Investigations, the CBC, LFT, RFT, serum Ig and absolute eosinophil count within normal limits. And serum ammonia, calcium, phosphorus, this serum electrolytes, albumin, everything was within normal limits, sir. And EEG, ECG, this was done like subsequently in references like neurology reference and those things. And it was within normal limits. In USG neck, we had diffuse thyroid swelling with heterogeneous echo texture suggestive of diffuse thyroid disease. And MRI brain, we had an incidental finding that is prominent retrocerebellar CSF space likely megacisterna magna in the midline posterior to the cerebellum, causing mild indentation over cerebellum. And also TSH level was low, sir, and also the serum prolactin level was high, that is 38.7.
What it says?
This hyperprolactinemia, like they are like any metabolic cause, really, with the abnormal investigations, any metabolic cause, endocrine issue to like.
Is there anything else we can think of higher hyperprolactinemia other than all this? What the treatment is on? Whether he's on any antipsychotics or something like that?
No, sir. No antipsychotic treatment, sir, till now in past.
What is the treatment is on? Some desvenlafaxine 75 milligram, you said? Is it on 75 or what is that?
Yes, sir. Yes, sir. 75 mg, sir. When he came, he was on 75 mg, desvenlafaxine 75 mg.
Yeah. What are the tablets, how they come? Desvenlafaxine?
Yes, sir. 37.5 mg, 50 mg, 75 mg.
Hey, Venla, you were talking about venlafaxine. What is desvenlafaxine? 50? 50, 100.
Yes, sir. 50, 100. Oh, sorry. 50 and 100.
Now he's on desvenlafaxine and some propranolol and flunarizine.
Yes, sir. Propranolol 40 mg and flunarizine 10 mg.
Sir, because Dr. Prashant sir is here, all the investigations neurological related was done under his guidance. Maybe he can enlighten us about the Prashant sir.
Madam, can you please repeat your question, please?
Sir, these investigations, whatever he put it across, ammonia,
Yes,
all that. So everything was done under your guidance. So we want to know what does it mean? Does it have any significance? MRI finding?
No, madam. MRI, that was only cisterna magna is an incidental finding that will not explain any of his symptoms. And regarding CSF was also normal. We wanted to rule out any infectious causes. Then ammonia, as I told, we wanted to rule out any urea cycle disturbances or something which is coming periodically and late onset metabolic disorders we wanted to rule out. So all these things came negative. So EEG was also normal.
During the episode or after episode? Sir, does it make a difference for us when we send a case?
But actually ammonia was done during episode, I understand actually. Okay. So, but EEG was actually done immediately after the episode subsided. But again, there was no epileptic form discharges in that time.
Okay.
Now, what is the diagnosis, Riaz? Now, with all this, did you do any psychological evaluation? Any, like Dr. Anil Kakunja said, dissociative scales and all that, whether you administered?
Scales we have not administered, sir. Like we'll planning to do it, sir. Like in the further follow-ups like that.
Your very idea for asking the patient to get me is come to a diagnosis and then go for treatment.
Yes.
Now, what is your diagnosis at this stage? Then you will go for treatment. What do you think? Do you have any doubts about anything? Because you got all the investigation done and you got it. Now, what is your diagnosis at this stage?
Sir, now it's like recurrent depressive disorder, current episode moderate depression with somatic symptoms and dissociative stupor, and with migraine headache.
You should add all the other medical diagnoses also, Riaz, like obesity is there.
Yes, sir.
You said some other medical problem he has. He is on cetirizine and something like that for.
Yes, sir. Urticaria. Yes, sir.
So all those things should come under the diagnosis.
Yes, sir. Yes, sir. Yes.
So you cannot miss obesity also because the drugs you add should not increase his weight again.
Yes, sir. Yes, sir.
Yeah, the other point I want to make is you have a big list of investigations and treatment, but probably you missed psychological assessments.
Yes.
Yes, sir.
So
That
if
has to
you
be done. Yes.
given a choice, which psychological assessment you want to do?
In
You said something about depression.
Child case, no? So it is, see, to get some information from the child sometimes is difficult. They say only headache, headache, headache. So
yes,
to make him speak, you can use something like a TAT, a CAT, a sentence completion test.
yes, sir.
Children, you
Thematic
can also
approach.
use something like draw a person test, draw your family, and so on. There are many
Yes,
ways
sir.
how you can make the child express.
Yes, sir.
Sentence completion, because he is a school going boy, sentence completion test probably will be quick and easy to administer. Even a TAT or a CAT should be fine. So that will
Yes,
give
sir.
you some idea about possible stress, what is happening in his life.
Yes,
He will tell some stories and you can get some information from that.
yes, sir.
And if a video EEG facility is there, that would be better than EEG, so that you know, a kind of confirmatory when he is having episodes of unresponsiveness. So it is 100% psychological.
Yes.
Any anti-anxiety drug you want to give?
Like tablet clonazepam 0.5 mg or 0.5
Yeah,
mg.
yeah. Sometimes small dose
Yes.
initially
Yes.
sometimes helps.
Yes, sir.
Yeah. Anyone else from the audience? Anyone wants to add, ask anything?
Sir, because I have also seen the case initially. I think we keep that episode of unresponsiveness aside. It's a very straight cut case of depression. But then those episodes also require a lot of, because they are more worried about that family members. 2 days he doesn't
Yeah.
get up, one day he doesn't get up. And I think we have to, there is a lot of overlay between many times neurological and psychiatric problems. So we have to keep our minds open and look for follow up, see him again and again, and maybe we should be able to revise our diagnosis whenever it's required.
Absolutely. So is the patient still in the ward or discharged now?
No, sir. He is discharged, sir. We are like he's coming for regular follow-ups, sir.
He feels much better. His functioning is better, but we don't know about these episodes. They have not happened, so we're just waiting. I mean, if it doesn't happen, then fine, it is gone. But then right now there are no stresses, and he's functioning well.
Good. Riaz, did you contact him after discharge?
Yes, sir. Yes, sir.
How?
Like we have his father's number and his own mobile number also I have, sir. Like
Yeah, good. That's a good way. So that as a postgraduate, you follow up and even you can do a telephone follow up, something like telemedicine.
Yes.
So you can ask them to update and he'll also feel nice that there is some connect with the treating team.
Yes.
Anything
Anil,
else?
how do
Yes,
you
sir?
feel about this case? Sincerely, personally, how do you feel about this case? What is your...
It's a very interesting case. Child cases are always challenging. And generally, child cases are more difficult compared to the adult ones.
Yeah.
And it requires more of a psychological intervention and dissociation, especially children dissociation. Parents are very much concerned. So it becomes an added responsibility for us to manage both the child and parents. And expectations are also very high. So it's actually a quite challenging case. And I think Riaz has done a good job.
And Riaz is a very enthusiastic gentleman. He was down with fever for past 1 week. I asked some other resident to present. But he said this is an opportunity for him to present this case. So he is with the drips and antibiotics and all that. So I appreciate his enthusiasm. So Riaz presented well. However, with some lacunae, his second year, I think he has to improve a lot.
Yeah, he will
So
learn.
yeah, that's how it is. Anything,
There's
any
just a
opinion from
question
the
in
others?
the chat box by Dr. Somshekhar Bijal.
Yeah.
Rationale for vaccine in CAP. He is actually a 17-year-old guy who is, I think, he might have crossed 18 years now. And he was already on vaccine 50 when he came to us. So and his initially episode also, I think he had improved. So that's why it has been increased. I think that's what Riaz want to tell, or anything you want to add?
So the question from Bijal is why they started on vaccine.
It was not started here. It was already 50 mg was there. We increased it.
Yes, ma'am.
Mobile use or online gaming history already.
No, online gaming as such, it's not there. He like his hobbies was playing football, so he used to watch football videos in YouTube and Instagram as such. Other than like his addiction basis.
It was not problematic usage.
It was not wrong.
Yes.
Sir, I think, shall we close?
Well, what about other PGs? I think they should open up and they should come forward with some questions.
They are setting, sir, a lot of them. We have taken all of them.
Any questions here? No. Pardon?
Okay.
Is it okay, Anil Kakunje sir? Is it fine? Shall we conclude?
Yes, I think
Dr.
did a good
Vinayak
job.
Bhatt wants to speak few words. Dr. Riaz, sir is there, our dean.
Yes, ma'am. Yes, ma'am. Sir.
Then we can conclude with out of thanks.
Yeah.
And the thing about the divalproate sodium, again, I am coming back to that. Somebody has put on divalproate sodium on the patient. And I think that has been tapered or taken off.
Taken off, sir.
Taken off, sir. Yes, sir.
Good afternoon, team. So it was very amazing to see how the online discussion has happened, how multiple specialists involved in the case discussion. There was an interactive discussion and a lot of learning has happened. I hope the other three PGs have noted the discussion part which has happened through the case discussion, so that if they make a summary of it, what is the lesson learned through this discussion, and keep it as a record, so that that will help in the proper documentation of the today's event.
Thank you, sir.
Thank you, sir. So I would come to the end of the program. Vote of thanks. I remember, I mean, whenever this child adolescent cases are discussed, when I was doing my PG in NIMHANS, Dr. Satish Girimaji sir used to always tell us that, don't be in a hurry to make a diagnosis in child or adolescent case. So there is a lot of kind of heterotypic continuity, homotypic continuity. So over time, it might change and things start falling into place. Things start showing themselves. So you need to be patient. Try to examine from all point of view. I mean, you don't get sticked on to this is dissociative, this is organic. No, you need to be open. I think that is what even now this case tells us, that you have so many things to think about and look for. And the best thing about the case is that Dr. Riaz has called him back and kept a rapport with him and wants to know the improvement. I would like to, first of all, at the outset, I would thank Dr. Riaz for a very good presentation. Though he was not well, he has managed to do it well. And this would not have been possible without a great moderators who come as PG examiners. Dr. Anil Kakunje and Dr. Harisha Delantabettu, both are professors, so who actually go as examiners. So you have the opportunity, luxury of having examiners at your home in your screen, and that's a great experience for all PGs. So thank you, Dr. Anil sir, and thank you, Dr. Harisha sir.
Thank you.
Thank you.
I would also like to thank our IMA President, Dr. Chinivalar sir, Honorary Secretary, Dr. Suri Raju sir, and our Ipskc President, Dr. Somshekal Bijjar sir, who has been there for the whole session and who has actively participated with the questions, many questions in the chat box. And Dr. Suresh VC, who has participated in our case conference. Thank you, sir, for being here. And I would like to thank, special thanks to Dr. Prashant sir, a neurologist. Getting an appointment with a neurologist, getting to talk with a neurologist, getting an appointment for your patient for a neurologist is very difficult. So I must thank Dr. Harish sir, who actually personally called up Dr. Prashant sir and asked him to join us. Thank you, sir, for joining us.
Thank you, madam. I should thank for giving me this opportunity. Harish sir.
Thank you. And I would like to thank our academic committee chairman, Dr. Narayan Murthy sir, for allowing us to do this case conference. And our department staff, Associate Professor Dr. Sai Komal and all other PGs and staff. And special thanks to Dr. Vinayak Bhatt, our Dean and Director of Subbaiah Medical College, for gracing the occasion. And thanks to all PGs who have been here and made it successful. Thank you, one and all.
How about thanking Dr. Subrata?
Oh, thank you, sir.
Yes.
Thank you, my pleasure.
Thank you, one and all.
Thank you, sir.
Thank you.
Thank you for the opportunity.
Thank you.
Thank you.
Thank you.